Welcome to the Deep Dive. Today, we are tackling a huge topic, one of the, I think, most successful, but also most complex areas in cardiovascular medicine.
Absolutely.
We're talking about managing heart failure with reduced ejection fraction, or HFrEF. And the sources you shared, I mean, they just paint this picture of constant, relentless scientific progress.
It's a remarkable journey, really. For decades, heart failure treatment was, well, it was mostly reactive. You were managing symptoms, fluid overload. You were treating the kidney, the hemodynamics.
But not the root cause.
Exactly.
Yeah.
Not the core disease progression. Today, we are firmly in this era of disease modification. It's all about neurohormonal antagonism.
So our mission for this deep dive is to really map out that entire shift. We want to look at the foundational drugs, the real game changers, and then touch on the emerging strategies that are defining care right now.
And the big takeaway, the thing you have to remember, is that these therapies, they do more than just help with breathlessness or swelling.
Right.
They profoundly improve quality of life, they slash hospitalizations, and this is the crucial part, they significantly reduce mortality, both from pump failure and from sudden arrhythmias.
That reduction in mortality really began with those original pillars, so let's just dive straight in there. Segment 1, the neurohormonal antagonist that kicked this all off.
Yes.
And we have to start with the RAAS blockers. The ACE inhibitors.
ACE inhibitors, yes. They were the first real paradigm shift. They proved that if you could modulate the renin-angiotensin-aldosterone system, you could actually change the course of the disease.
That effect was huge.
Monumental. I mean, meta-analyses consistently show a 23% reduction in all-cause mortality. They are, without a doubt, a cornerstone for pretty much every HFrEF patient.
Okay, but what about the side effects? If a patient gets that, that really persistent dry cough or something worse like angioedema, what are the trade-offs if you switch them to an ARB?
Right, so that's where the ARBs, the angiotensin receptor blockers, come in. They work a step further down the pathway, blocking the receptor directly. So you bypass the mechanism that often leads to that cough.
And the efficacy is similar.
Trials establish that they have comparable efficacy. They are a perfectly suitable and safe alternative for patients who just can't tolerate an ACEI. You can argue the primary data slightly favors ACEIs, but for those intolerant patients, ARBs are a lifesaver.
Now let's talk beta blockers, because here we have to be really, really precise. It's not a class effect, is it?
This is such a critical distinction. It's something every clinician has to remember. In HFrEF, there are only 3 specific agents that have been proven in large clinical trials to improve survival.
Which are?
Carvedilol, bisoprolol, and metoprolol succinate. Only those 3.
So why is that so important? What is it about other beta blockers, especially the ones with intrinsic sympathomimetic activity, that makes them ineffective?
Well, the whole benefit in HFrEF comes from completely and sustainably blocking the sympathetic nervous system. You're trying to let the heart rest and repair.
Right.
Agents with that intrinsic activity, ISA, they actually partially stimulate the beta receptors even as they're blocking them.
So it's like taking one step forward and half a step back?
Exactly. You don't get that crucial sustained drop in resting heart rate and sympathetic tone that you need to reverse remodeling. They fail to provide that same life-extending benefit.
Okay, so we've got our specific ACEI or ARB and one of those 3 beta blockers. The sources suggest the order you start them in doesn't really matter.
That's right. The CIBIS III trial found the sequence doesn't matter much. What does matter, and this is probably the most important point, is timely and aggressive titration.
Getting the dose right.
Getting the dose up. Trials like ATLS and HEAL show time and again that pushing patients to the higher target doses used in the trials results in significantly better outcomes. Fewer deaths, fewer hospitalizations.
But when you look at the real world, at the big registries, that's not what's happening, is it?
No, it's a huge challenge.
If the evidence is so clear, why is this guideline-directed therapy so often underdosed?
It's a mix of things. Clinical inertia, a fear of side effects like hypotension, and just the sheer complexity of managing all these medications. Clinicians get nervous about pushing the dose, and that gap between what the trials prove and what happens in practice is one of the biggest failures in HFrEF care today.
So before we get to the newer drugs, let's round out that original trio with the MRAs, the mineralocorticoid receptor antagonists.
Right. MRAs like spironolactone and eplerenone, they add this essential third layer of blockade.
Because aldosterone is still a problem.
It's a huge problem. It promotes fibrosis, potassium loss, sodium retention, all things that are bad for a failing heart. The Rallis study showed powerfully that adding an MRA gives you further reductions in morbidity and mortality right on top of the other therapies.
And the choice between spironolactone and eplerenone often comes down to side effects.
Exactly. Spironolactone can have those anti-androgen side effects, like gynecomastia. Eplerenone is more selective, so it's a great alternative for patients who run into that issue. The key caution for both, though, is you have to watch the potassium and kidney function very closely.
That brings up a great point about combining these agents. There was a time when the thinking was if blocking RAS is good, maybe blocking it in 3 different places is even better. What did we learn from that?
We learned a vital lesson. We learned there's a ceiling of benefit and that more is not always better. The idea came from this thing called neurohormonal escape, where angiotensin II levels can creep back up over time.
So researchers tried combining an ACEI and an ARB, or an ACEI and a direct renin inhibitor.
They did. And the trials, Valiant and Atmosphere, were decisive.
In not a good way.
Not at all. The combinations added zero clinical benefit over just maximizing one agent, but they significantly increased adverse effects. More hypotension, more hyperkalemia. It led directly to the current guideline. Do not combine these agents.
Well, that failure really set the stage for a completely new approach, which brings us perfectly to segment 2, the new game changers. And we have to start with the ARNI's sacubitril valsartan.
This was such a clever drug design. The ideal was to hit 2 pathways at once. You use valsartan to block the angiotensin receptor like a normal ARB.
Right.
But you combine it with sacubitril, which inhibits an enzyme called neprilysin. And neprilysin's job is to break down your body's own beneficial natriuretic peptides.
So you're blocking the bad stuff and boosting the good stuff simultaneously.
That's the goal, synergy. And the Paradigm HF trial was just the ultimate proof of that concept.
How dramatic were those results?
They were stunning. They compared the ARNI to enalapril, which was the gold standard. The ARNI group had a 20% reduction in cardiovascular death, or HF hospitalization, and a 16% drop in all-cause mortality.
Wow.
The trials actually stopped early because the benefit was so overwhelming. It just became the new standard for symptomatic HFrEF patients.
Now, for clinicians, there is a really important safety step when you switch a patient from an ACE inhibitor to an ARNI, that 36-hour washout period. Can you just walk us through why that's so critical?
Certainly. So neprilysin, the enzyme that sacubitril blocks, it doesn't just break down natriuretic peptides, it also breaks down other things, including bradykinin.
And ACE inhibitors also increase bradykinin.
Precisely. So if you have both drugs on board at the same time, you get this massive accumulation of bradykinin. And that is what causes angioedema, that rapid, dangerous swelling of the lips, tongue, and throat. The 36-hour pause is absolutely essential to let the ACE inhibitor wash out of the system and prevent that risk.
That is a crystal clear explanation. Okay, so from a purpose-built drug to, well, maybe the biggest surprise in the whole field, the SGLT2 inhibitors.
A complete surprise, yeah.
These were drugs for type 2 diabetes, and yet they have this massive diabetes-independent benefit in heart failure.
It's one of the best stories in medicine recently. Drugs like dapagliflozin and empagliflozin were made to help you excrete glucose through the kidney. But right away, in trials like MRA, they saw this unbelievable 35% reduction in HF hospitalizations.
And the key finding, which was confirmed later in trials like DAPA-HF, was that this had almost nothing to do with blood sugar.
Almost nothing. The benefit, a consistent 25-26% reduction in outcomes, was the same whether you had diabetes or not.
So what's the theory? How are they working?
It's probably a few things. There's a mild diuretic effect that reduces volume without kicking the sympathetic nervous system into overdrive. But the really fascinating theory is about a fuel switch for the heart.
A fuel switch?
Yeah, the failing heart becomes really dependent on glucose, which isn't very efficient. SGLT2 inhibitors might push the heart muscle to use more efficient fuels, like ketones or fatty acids, improving its overall energy use and function.
So regardless of the exact mechanism, the evidence was just so strong that they became a foundational therapy.
They're now the 4th pillar. So the standard of care is now ideally 4 drugs: an ARNI, a beta blocker, an MRA, and an SGLT2 inhibitor.
That's the new foundation. But of course, the research doesn't stop, especially for patients who are sicker.
No, it never does.
Which brings us to segment 3, advanced and adjunctive strategies. Let's start with a really novel mechanism, myosin activation, with the drug omecamtiv mecarbil.
This is a completely different approach. It's trying to mechanically improve how the heart squeezes. It's an oral drug that basically makes ventricular systole last a little bit longer.
So it makes the contraction more effective.
More effective, yes. And it does this without increasing the heart's oxygen demand, which is what made older inotropic drugs so dangerous.
And the big trial, GALACTIC-HF, it showed a benefit, but it was a specific kind of benefit, wasn't it?
It was. It showed a 14% reduction in the main outcome, but that was driven almost entirely by reducing heart failure events, not cardiovascular death on its own.
So what does that tell you about where it fits?
It suggests its role is probably in patients with more advanced heart failure. Patients who are already maxed out on the 4 pillars, but still need that extra mechanical boost to stay out of the hospital.
Okay, another one for those higher-risk patients is vericiguat, an SGC stimulator.
Exactly. The Victoria trial specifically looked at patients who had just had a worsening heart failure event, meaning they were just in the hospital or needed IV diuretics. These patients are at incredibly high risk of coming right back.
And how does vericiguat work?
It stimulates an enzyme, soluble guanylate cyclase, which is part of the nitric oxide pathway. The end result is vasodilation and reduced stress on the heart.
And the result was modest?
It was a 10% relative risk reduction, again, mostly driven by preventing that next hospitalization. It's not a home run like the other drugs, but it's another potential tool for that very high-risk revolving door patient population.
Sticking with these adjunctive therapies, what about heart rate modification with ivabradine? This feels like a very targeted tool.
It's a very specific tool and a very useful one. It works by inhibiting what's called the funny current, or if current, in the heart's natural pacemaker.
So it just slows the heart rate down.
It just slows the heart rate, but crucially, it doesn't affect contractility or blood pressure. This makes it perfect for patients who are still symptomatic with a heart rate over 70, especially if they can't tolerate higher doses of their beta blocker.
And the HFrEF trial supported that.
It did. It showed a reduction in the combined outcome of CV death or HF hospitalization for that exact group. It's an important way to get that heart rate burden down when beta blocker titration just isn't an option.
Let's quickly touch on some of the older agents that have sort of fallen out of favor. Digoxin. What's the final word on digoxin?
Digoxin is now very late-line therapy. The DIDE trial settled it. It reduces hospitalizations, but it gives you absolutely no mortality benefit and no proven improvement in quality of life. And importantly, it might actually be associated with higher mortality in women, so you have to be very cautious.
And what about the combination of hydralazine and nitrates?
They do improve survival, just not as well as ACE inhibitors. Their role now is really for patients who absolutely cannot take any RAS therapy, maybe because of severe kidney problems or hyperkalemia. And we should mention the HFrEF trial, which showed a particular benefit in self-identified African Americans.
The big drawback being the dosing.
Yes, 3 times a day. Yep. Adherence is a real problem.
And just to close this section, we should remember the failures. Statins and anti-inflammatory drugs just didn't pan out for non-ischemic heart failure.
They didn't. Trials like Corona and GISI-HF showed no benefit from statins in this population, and trying to block inflammation was either unsuccessful or, in some cases, actually made the heart failure worse.
That is a perfect setup for segment 4. Because the drugs can only go so far, you have to look at devices and lifestyle changes.
These are the mechanical and behavioral supports for that optimal medical therapy. Let's start with devices. First, cardiac resynchronization therapy, or CRT.
CRT is all about fixing a timing problem, right?
Uh-huh.
Mechanical dyssynchrony.
Exactly. When the heart's electrical system is delayed, you often see a wide QRS on the EKG, especially with a left bundle branch block. It means the 2 ventricles are pumping out of sync. It's incredibly inefficient.
And CRT fixes that.
It uses pacing, leads to recoordinate, to resynchronize the contractions. The pump becomes much more efficient. And trials like CARE-HF proved it reduces all-cause mortality. It's a huge benefit, especially for patients with a very wide QRS.
The second major device is the ICD, the implantable cardioverter defibrillator. This is about preventing sudden death.
Yes. You have to remember, about half of all deaths in heart failure patients are sudden cardiac deaths from a ventricular arrhythmia, especially in the earlier stages.
So who is a candidate from ICD?
The guidelines recommend them for primary prevention in any symptomatic patient with an LVEF under 35%. Also for patients post-heart attack if their LVEF stays below 30%.
But that's a serious conversation to have with the patient.
Oh, absolutely. ICDs save lives, but they can deliver painful, psychologically jarring shocks. For patients who are really end stage or have a limited life expectancy, you have to weigh the survival benefit against the very real burden of those shocks.
Okay, finally, let's just touch on the non-drug, non-device supports.
Right.
Supplements, things like fish oil or micronutrients.
The evidence there is a bit lighter. Omega-3's fish oil did show a modest benefit in the HFrEF trial. And we know that very severe deficiencies in things like thiamine or selenium can cause a reversible heart failure. But
But we're not routinely testing everyone.
no, we're not at a point where routine supplementation is recommended for all patients. The evidence just isn't as strong as it is for the four main drug pillars.
So to wrap this up, we've really mapped a monumental shift here. We've gone from just a couple of drugs for symptom relief to a standard of care that involves stacking 4 different classes of disease-modifying agents, often with a device on top of that.
And the theme that comes through in all the sources is that success isn't just about picking the right drugs. It's about the optimization of that therapy.
The titration.
Aggressive titration to target doses and knowing which combinations to use and which to avoid, like that triple RAS blockade. That's how you get the incredible life-extending benefits that we're seeing in the clinical trials.